Dr. Kurt is a cognitive and behavioral neurologist. She completed her neurology residency at the University of Washington in Seattle, which we seem to have increasing direct connections to, and then trained in cognitive and behavioral neurology at BU in the VA in Boston. She joined the Boston University Neurology faculty in 2008, where she is now an assistant professor of neurology. Her research is focused on electrophysiological biomarkers of neurodegeneration. She is a recipient of the Alzheimer's Association Award for her work examining the use of event-related potentials in a memory disorders clinic, and was recently awarded a VA Career Development Award for her work investigating mild traumatic brain injury as a risk factor for neurodegeneration due to Alzheimer's disease and CTE in veterans. And I also just want to give a shout out for her exceptional work at the BUADC in terms of outreach for participants. She and Andrew have really done a tremendous job. So with that, I'm going to turn it over to Dr. Turk.
Thank you so much, Rhoda, for that introduction. Today, I'm going to be talking about several years of work in our clinic, looking at EEG and event-related potentials among veterans with memory disorders. So my disclosures are here. We didn't have any funding from the company, but we got use of their EEG device and electrodes at no cost. So giving some background about biomarkers in Alzheimer's disease, currently in clinical practice, we use CSF biomarkers of amyloid and tau, and also amyloid PET imaging. Each technique has benefits and detractions. So in terms of the CSF markers, this is an invasive procedure. We can't do it on every patient, and it's not ideal for longitudinally following someone. In terms of amyloid PET imaging, it's a powerful technique. It is FDA approved, but it's not currently reimbursed by insurance, so can be difficult to meet the clinical burden, in private practice. We're lucky we do have access to it at the VA, but there are other downsides. It's expensive and involves radiation exposure. So it would be nice to sort of find a new biomarker that is able to reflect some of the pathophysiology of Alzheimer's disease and doesn't have some of those detractions. So this is just a slide detailing some of the possible steps that lead to Alzheimer's disease. It's a very kind of cartoon version of what might be happening in the brain, but we think maybe amyloid beta accumulation is occurring first. And the red line there. And then patients have synaptic dysfunction in the orange line, which might be seen by functional fMRI or FDG PET. Following that, there may be tau-mediated neuronal injury that you might pick up in CSF studies. Much later on, you actually see changes in brain structure by MRI and cognitive changes and clinical function changes, which happen much later in the disease course. And by that time, neurologists like myself are finally seeing patients in the clinic, but really we'd like to detect them much earlier when we might be able to change the disease course over by the red or orange lines. So event-related potentials are a possible biomarker, candidate biomarker that's being explored. They represent quantitative EEG waveforms that are time-locked to a cognitive task that we ask a participant to complete. So their advantages, there's a high level of temporal resolution on a millisecond level. They can assess synaptic function, so one of those lines in the pathophysiology sort of much earlier on. And they also correlate to a cognitive process that we're asking someone to complete. So these waveforms are examples of EEG waveforms in response to a stimuli that we present to individuals. And you can see that the stimuli are repeated many times and then averaged together to improve the signal to noise ratio. And then the final output is what you see in the bottom right corner, which is a nice smooth waveform with peaks and valleys. And there's a sort of nomenclature with the N's being the negative peaks and the P's being positive, and then voltage on the y-axis, and then time in milliseconds on the x-axis. So this is called a grand averaged ERP waveform in the bottom right corner. So we had some outstanding questions initially that motivated this project, whether event-related potentials could be an effective biomarker of Alzheimer's disease or other dementias. And to consider something a technique an effective biomarker, it should fulfill a few characteristics. So we want it to reflect a fundamental feature about the pathophysiology of AD. We also want the biomarker to be ultimately validated with the neuropathology, which is the gold standard confirmation of Alzheimer's disease. The biomarker should be precise and able to detect the disease early in the course and distinguish it from other neurodegenerative dementias. We also want the measurement to be reliable, minimally invasive, easy to perform, and inexpensive. So what are some of the advantages and limitations of ERP? Well, it's cost effective compared to some of our current techniques, probably on the order of a couple $100 to run versus thousands for amyloid PET studies outside of a clinical environment like the VA. They can run, $5,000 to $7,000. ERPs are non-invasive, don't use radiation, and don't have side effects. And then our rig can be quickly administered within 35 to 45 minutes. But there are limitations. ERPs and EEGs don't localize well, and they also don't measure amyloid load directly. But ERPs offer new opportunities. So ERPs have been around for decades, but have been revisited more recently because of more standardized acquisition methods that allow the acquisition to sort of be repeatable across the country in different labs and different clinical environments, and the measures to be directly compared. FDA approval, at least for the device we used, has occurred. And then ERPs, there are some outstanding questions. Could ERPs alter clinical diagnosis and management? And one additional potential question is whether ERPs might be measuring the synaptic sort of performance in a way that goes beyond the amyloid hypothesis. And they could potentially be used in addition to PET or CSF studies that are currently used in clinical practice. So a study in 2015 by members of our group found that ERPs are able to distinguish mild Alzheimer's disease from healthy controls. And this is an example of some of the stimuli repeated here across this top, and then the waveform from the study, the grand average waveform in the bottom right. So you see the healthy control waveform in blue and the mild AD waveform, and you can just see visually with the eye that what's called the P3B waveform there has a much lower amplitude in the mild AD population. And what's less visible is that the latency, or the time it takes for the peak to occur, is also prolonged in the mild AD group. So those were just some of the waveform differences that occurred. So in the bottom left, you can see an example of the headset that we used and that was used for the study. So the paradigm that we use when using the ERP is called an auditory oddball paradigm. It's the most commonly used paradigm within the Alzheimer's literature, and it involves 3 different auditory tones played through a set of headphones. And there's a standard tone labeled there in S, a target tone, which is higher pitched, and a distractor tone, which sounds like white noise. And the participant is asked to button press for the target tone, which is relatively infrequent, while ignoring the standard and distractor tones. So we also get some behavioral information as well as the ERP waveforms. So today I'm going to be talking about data from 3 different ERP projects that we've completed over the last few years. The first is looking at malingering and effort in cognitive impairment and the use of ERPs there. The second will be looking at ERP measures and their correlations with neuropsychological measures in our memory disorders clinic population. And the third will be looking at ERPs and head injury in older veterans who are reporting cognitive impairment. So the first project, we looked at malingering and ERPs. So just a little bit of background about the clinical evaluation of effort and malingering. So neuropsychological effort is generally measured by validated tests like the test of memory malingering or the TOMM. The TOMM relies on memory specifically versus other cognitive domains and can be relatively easily manipulated. Participants can be coached, and there's actually a lot of information online about how to perform on the TOMM. This can be a concern in other clinical populations outside of AD. And there's a secondary problem within the dementia population, which is that dementia patients and Alzheimer's patients, by definition, don't perform well on memory tests. So although they may be providing full effort, they may fail the TOMM, and they may be mistaken as an individual giving poor effort. And this is a concern for neuropsychologists. So we were hoping to sort of develop an alternative effort measure beyond the TOMM using event-related potentials. So we hypothesized that older controls who are either honest or malingering, so feigning poor effort, would be distinguishable from Alzheimer's patients based on their P300 peak amplitudes, and that they would have very differing performance levels on the behavioral measures of our paradigm. So why we used ERPs to look at malingering. So the auditory oddball P300 paradigm, which I described previously, does have a button press, so a behavioral outcome. And it's this task is less memory-based than the TOMM. We think it's more like attentional and working memory-based. And then the P3B in general is thought to relate to working memory and stimulus recognition. And we know that its amplitude is decreased in Alzheimer's disease versus healthy controls and may reflect the amount of attentional resources that participants can use during the task. And then we also know that latency is prolonged in Alzheimer's disease. There's been prior ERP literature looking at malingering in other populations. So in traumatic brain injury, ERPs have been useful to detect effort and healthy younger adults and older adults, but no one had previously looked at malingering in older adults who have symptoms of cognitive decline. So our design, we had 20 older controls, and we asked them either to simulate dementia or honestly complete the TOMM, the test of memory malingering, and also to complete our ERP auditory oddball protocol. For the simulators, we gave them a checklist of common dementia symptoms that someone with Alzheimer's disease would display. And for the 20 Alzheimer's disease patients, we had them complete one visit where they performed the TOMM and the ERP paradigm honestly. So for our headset from Cognition, it has 7 electrode sites, which are pictured there above, and a couple of references. And this is what the test of memory malingering looks like to participants. So on the left, you see in the study phase, participants are shown just pictures of objects without any words, and they are given 50 items. And then at test, there's a 1-to-1 ratio between old and new items. So they would be asked whether the leaf or the boat was the old item. And generally a normal score is nearly perfect. So this is actually a pretty easy task to perform. So these are the demographics of our groups. You can see that age was not different between the two groups, but education was lower in the Alzheimer's group as expected. And then on our neuropsychological battery, In terms of all the measures, the Alzheimer's group performed poorly and performed in the impaired range. So these were our ERP results. In black, you can see the older controls who are simulating in the simulating condition, and then you actually see the same group performing in another condition at another visit, performing honestly. And you can see that their P3B amplitude is not visually different. It wasn't statistically different either. And then in red far below, you see the Alzheimer's disease P3B amplitude. And that's in keeping with prior literature that shows that P3B amplitude is reduced in Alzheimer's disease. But what's new here is that we see that there's stability in the P3B amplitude regardless of behavioral performance on the task for the older controls. So this is just another illustration of the prior slide, but you see how much stability there is for individual participants between the simulator and honest conditions for the P3B amplitude. So what does all this mean in terms of the utility of adding the P300 amplitude to traditional measures like the TOMM? Well, on the left, we can see a receiver operator characteristic curve analysis of the use of the TOMM trial 2 results alone to detect the simulators compared to the Alzheimer's population. So a receiver operator characteristic curve can show that a technique is highly sensitive and specific if it's the curve sort of goes all the way up to the top left corner, and the larger the area under the curve, the better. So a perfect curve would have an area under the curve of 1, which isn't really possible for any test, and be all the way up in the top left corner. So we can already see that the TOMM trial 2 performs pretty well in our population for simulators compared to AD, with an area under the curve of 0.95, sensitivity of 95%, and specificity of 80%. So trying to beat that by adding the P300 amplitude, we see a slight improvement in our area under the curve in the right analysis when we add the P3B target amplitude to the TOMM trial 2. And the sensitivity and specificity of the analysis improves as well to 100% sensitivity and 90% specificity. So we had an additional question in this project whether the reaction time and behavioral measures would be useful as well to detect the difference between the two groups and the effort. So we looked at distractor response time, and we thought that the distractors and button presses to them might represent a deliberate choice on the part of the simulators to try to provide a false response, and that this choice in cognitive processing may take a long time to occur and longer than a button press to a target tone, which would be more immediate and honest. So we created a measure using the distractor response time and subtracting the target response time. And we looked at the differences between the three groups and conditions. And we found that the distractor minus target response time for the simulators was elevated and was able to distinguish between the groups. So a similar analysis, again, is the same curve on the left of the TOMM2 sensitivity and specificity. When we add the distractor minus target reaction time in addition to the TOMM, we see additional improvement in sensitivity and specificity. So what can we conclude from this data? So decreased P300 amplitude might be non-manipulatable and might allow reliable detection of Alzheimer's disease versus those providing poor effort, and might be used in addition to the TOMM. And we can also use behavioral measures like the distractor minus target reaction time. And these effort measures might be ready for use clinically. You know, we've thought about sometimes using them in certain clinic patients where we're wondering, you know, are they providing full effort or wondering about the underlying etiology of some of their testing. So in the future, we plan to implement some of these techniques and measurements in veterans with head injury and also to use divided attention paradigms. That's the first project. And now I'll be transitioning to talk about ERP measures and neuropsychological measures and their correlations. So one of the main measures in our battery that we investigated was TRAILS-B. TRAILS-B is an old neuropsychological measure very commonly used in clinical practice and is thought to be sensitive to brain damage. It reflects executive function and other cognitive abilities, psychomotor speed, and visual scanning. So you can see on the right an example of TRAILS-B, which has numbers and letters in it. And we asked participants to connect the numbers and letters in order, alternating order, and to do it quickly and without errors. So a correct response here would be to connect with a pen 1A, 2B, and so on. So P3B we talked about previously, but I'll just add that P3B latency the amount of time it takes the curve to occur has been found to be predictive of amyloid PET status by other groups. And we know that it differs in AD and healthy control populations. So we looked at TRAILS-B time and P3B target amplitude and their correlations, and found that sort of correlating in an expected direction, the higher the P3B target amplitude was, the less time it took participants to complete TRAILS-B. So this is in a population of 118 memory disorders patients. And we also controlled for age and education and the relationship held. So we think that TRAILS-B may reflect longer processing times required to complete a task, but intact ability to complete a task. And P3B could be a physiologic measure of longer processing speeds during an executive function task. So we also looked at other neuropsychological measures in our battery and how they correlated with P3B. This is the CRAD delayed recall measure in our battery. So this is a word list recall of 10 items. And we ask how many items they recall freely 5 minutes later. And out of 210 memory disorders patients, we see a correlation between increased recall in this measure and improved P3B target amplitude or elevated target amplitude. And then similarly for encoding sum, the more words encoded in the first 3 trials, the higher the P3B target amplitude for our population. And this, in this particular correlation, we included healthy controls and memory patients. And then similarly for corrected recognition, where we subtract recognition, recognize words from false positives, we see a similar relationship. So conclusions and future directions here, P3B target amplitude correlated with CRAD, corrected recognition measures after correcting for multiple comparison, and there's a trend towards significance for P3B target amplitude and CRAD encoding and delayed recall. So prolonged P3B target latency could represent a physiologic measure of longer processing speeds during an executive function task. So finally, I'm going to shift gears to talk about event-related potentials and imaging in older veterans who have cognitive deficits in our memory disorders clinic and also reported head injury. TBI in veterans is a common clinical problem. 17% of military service members report TBI during their deployments, and most of these injuries are mild. Right now, we don't have many objective clinical methods to diagnose mild TBI remotely, so neuroimaging, neuropsychological measures, and other methods are of limited diagnostic utility. Older patients are at risk of neurodegeneration because of remote TBI, but they present a challenging clinical conundrum for us. So when they present with a prior TBI, we're not sure whether their cognitive deficits could be related to the prior TBI versus Alzheimer's or CTE. or to what degree the TBI is contributing to their picture. So a physiological marker of prior brain trauma would be helpful, and ERPs are an ideal candidate. We investigated the P50 ERP measure as a possible marker of prior TBI. P50 is an early or preconscious ERP response that's thought to be generated by primary auditory cortex as well as frontal lobes. And it's thought to be involved in a cognitive process called sensory gating. Sensory gating is the ability of the brain to suppress a response to an expected and repeated stimulus. So an example of this from real life would be if you were at a cocktail party and a noisy environment and heard lots of people talking at once, having the ability to sort of shut out all of that extraneous sound and focus just on your conversational partner and the conversation at hand would be an example of effective sensory gating that we all put into practice. Someone with impaired sensory gating might not be able to shut out the extraneous stimuli and inhibit it. Our hypothesis was that P50 latency is increased in memory patients who have a history of head injury versus those without a history of head injury. So this is a visual example of the P50 target latency occurring about 50 milliseconds after stimulus onset. We also had some secondary questions whether head injury exposure increases risk of neurodegenerative disease in the memory disorders population. So there were a couple of competing hypotheses in the literature. One is that head injury exposure may lead to increased dementia risk. So repetitive head impacts, whether concussive or subconcussive in the form of RHI, are strongly linked to CTE through a large body of literature. TBI has also been linked to dementia risk in epidemiological studies of civilians and veterans. But there's a competing line of evidence that perhaps mild TBI patients recover from their injuries within 3 months, in most cases, without lasting cognitive sequelae. So our hypotheses were that veterans in the memory disorders clinic with head injury would show increased rates of neurodegenerative clinical diagnoses compared to those without head injury, and that amyloid PET positivity compared to those without head injury, there would be higher rates of amyloid PET positivity in the group with head injury, and that the veterans with reported head injury would also have relatively increased prevalence of a cavum septum pellucidum. So in the right corner, you can see an example of a cavum septum pellucidum, which is just the separation of the two central leaflets in the brain, and is thought to be a marker of prior head injury. And then on the left, you can see an example of amyloid PET positivity in an Alzheimer's patient. So to test these hypotheses, we looked at neuropsychological measures and our auditory oddball P300 paradigm, as well as imaging measures in 70 older veterans from the Memory Disorders Clinic with a history of head injury and 54 veterans without head injury exposure. And this was the demographics table. So you can see our ages, the ages were not different, education did not differ, but there were differences in MoCA and MMSE. So in general, the head injured group was actually less impaired. And then similar pattern for the CRAD, wordless memory test, our TBI group was less impaired. But importantly, for the GDS and CNS, which are a mood lability scale and a depression scale, there were actually elevated rates of mood symptoms in our head injured group. So this is a chart showing the different neurodegenerative diagnoses within the two populations. And the clinical diagnoses that we made. And these were the P50 target latency differences between the groups. We found that P50 target latency was significantly longer in the head injury group versus the non-head injury group. And then these are the outcomes for the rates of cavum in the two groups and the amyloid PET positivity, as well as the neurodegenerative diagnoses. So there was actually no difference in the CAVM rate between the two groups. And surprisingly, the amyloid PET positivity was less prevalent in the head injury group, and neurodegenerative conditions were less likely in the head injured group. So we also performed some regression analyses with the P50 target latency. We found that it was a significant predictor of head injury status, but it was not a significant predictor of neurodegenerative clinical diagnosis, and was also not a significant predictor of amyloid PET positivity. We also looked at potential confounders of the P50 latency increase in the head injury group. So whether vascular risk factors and white matter lesion load predicted P50 latency, and we did not find a relationship between these potential confounders. And then psychiatric and mood disorders also did not predict P50 latency. We also looked at sub-analyses where we looked at differences in the P50 latency between those with mild TBI and moderate TBI, and we didn't find differences, but we had a relatively low N for the moderate TBI group. We also performed some regression analyses looking at neurodegeneration, and we looked at whether head injury predicted neurodegenerative clinical diagnosis, and found that it predicted the absence of a clinical neurodegenerative clinical diagnosis, and that head injury predicted a negative amyloid PET study, and the presence of a CAVM was not predictive of neurodegeneration. So summarizing these findings, we found that head injury is less likely to be associated with neurodegenerative disease in our memory disorders population. And we were wondering why this is. So prior epidemiological studies in the general population have found that head injuries are linked to increased risk of neurodegeneration at the population level. So it could be that once a patient arrives at a memory disorders clinic, the head injury itself could be an alternative etiology for relatively static cognitive deficits in terms of why they're presenting to the clinic. And that we could also just have difficulty in detecting underlying CTE right now, given a lack of existing biomarkers. So we did identify a group within the study that had TBI and repetitive head injury, and we'd like to follow them longitudinally and follow their progress using other ERP measures. So what can we conclude from our P50 study? That increased P50 latency may be seen in older veterans who've had prior head trauma, and that the measure is related to head injury itself, not to neurodegeneration. Perhaps the prolonged P50 latency could be related to underlying axonal damage resulting from the TBI, and it could be related to frontal temporal network interactions, and that P50 is thought to be generated by the auditory cortex and also has frontal inputs. So our next steps are to look at P50 in younger veterans who've had mild TBI. So I'd like to thank everyone in our lab at the VA and also the Alzheimer's Association and the VA for funding support. Thanks so much.
If anyone has any questions, we'll take them now.
Hi, Kate. This is Tor. Great talk. Really interesting. I find it particularly interesting that the amyloid was decreased. I wonder if it's maybe due to the type of amyloid. I think that the amyloid PETs pick up more than neuritic plaques, and less so the diffuse plaques. And we see in our autopsy population of CTE that they are more likely to have diffuse plaques, which seems to occur maybe at a little younger age, but the neuritic plaques are not maybe as frequent as you might expect. We haven't really looked at it formally, but one hypothesis is that there's the inflammation that's present or that's going on may actually be partially protective, or may actually be preventing that type of neuritic plaque formation. So that's something we're interested in following up on. I found that interesting. I wonder, a question if you have any MRI data to look at like atrophy patterns, because that I would predict may be more involved.
Yeah, so thanks for the comment about the amyloid PETs and how to interpret that. I was kind of puzzled by that result, but I think something we're planning to do together, which is also to look at the CSF measures in this population, veterans with head injury, might provide more light if we see elevated amyloid there in the CSF. And then in terms of the MRI, yes, we are working with David Salat, and we're actually just starting to analyze the data from this cohort. So we have probably about 200 MRIs that we'll start adding to the data set.
Kate, great talk. So I wanted to follow up on the selection bias piece and how being in a memory disorder clinic might be contributing. So with a VA population, you have a very unique opportunity to know the demographic characteristics of folks who are not in your memory clinic but are part of the VA. And you could potentially identify predictors that you have information, demographic predictors, for instance, that are specific to your memory clinic and compared to the general population of VA patients. And then you could use that to do inverse probability weighting and weight folks based on what they're like in the general population. And that might get you a better relationship between TBI and your outcomes.
Yeah, I think that's a really great idea. We have approached the primary care groups to sort of recruit non-cognitively impaired veterans in the past, but I think it's worth setting up a partnership and sort of getting more of a proxy for the general population, like you're talking about. In terms of the inverse probability weighting, I don't know how to do that, but I'd love to talk to you more about what that would be or what that would look like. But I agree that's probably, that bias is probably why we didn't find what we were expecting just in our memory disorders population.
Right, so here you wouldn't need to recruit anybody different. You just need the characteristics, like the demographic characteristics of the VA population. And then you could integrate that into your regressions. So, so it would be, it'd be purely a statistical approach.
Okay, cool. Yeah, I'd love to learn more about that from you.
Okay, it seems like there's a question in the chat box.
Sure. So the question is, does the data support that head injury presents as a risk factor to memory-related disorders? So far, no, we haven't found a direct link between head injury itself and having Alzheimer's disease or a neurodegenerative condition. It just seems more likely that there's mood disorder in the TBI if you've had a TBI in our population.
Thank you. Does anyone else have any more questions? All right, well, I want to thank you, Kate, so much for putting on this talk for us. And thank you everyone for joining. I'm going to send out a recording of this session to everyone later on, as well as an evaluation, if y'all can fill that out for us. All right. All right, well, thank you so much, Kate, again.
Thanks,
Everyone have a great day.
Bye.
All right, bye.